And then that kitchen table, I remember, was, oh my goodness,
Yeah.
this is at our doorstep, because
That's
it is transfusion related.
This is Professor Harry Buehler from the AMC in Amsterdam. I am Mallika Shekhar, a haematologist in London, UK. Welcome to my podcast series called The Bitter Pill, that looks at lessons that we doctors may learn from history. I met Harry and two of his colleagues at the AMC in 2019 to discuss the HIV/AIDS crisis in their haemophilia patients in the 1980s. In 1982, the NEJM and the Lancet reported AIDS related to transfusion. This had huge implications for patients with haemophilia everywhere because they were being treated with factor concentrates prepared from large volumes of pooled plasma. Most of this material were imported from USA. As it turned out, AIDS struck haemophilia communities differently across countries. In the Netherlands, some 15% of their haemophilia patients had AIDS, compared to 50, even 80% elsewhere. What did they do right? Let's hear their discussion. Harry is timeless, and he is renowned for his work in thrombosis and for his mentorship of many trainees. Dr. Madeline Peters was a pediatric hematology fellow at that time. She retired from practice in 2019, just a few days after I met them. She made a video for her patients as a goodbye gift. Professor Jan Wouter ten Kate headed the Haemophilia Center at the AMC in the 80s. At the time I met them, Prof. ten Kate was recovering from a stroke. This podcast is called Amsterdam.
That was the shock, because I think there were two elements. One is ignoring the problem, so it may not affect us.
It was something in the US.
Right.
It was in California.
Okay. Far away from
our safe Dutch country where we have not paid donors, isn't it?
No, that's what I'm trying to say. We are not going to be affected. So just ignoring the problem.
So we are not going to be affected in the haemophilia population because you already had gay homosexuals.
In the gay community, it was a massive problem.
So the disease was there, but
the disease was there, but the relation to my patients, so to say, I think, like I'm afraid with every big problem, it was first trying to ignore the problem and felt comfortable by the fact that our blood banking system would be so good that we would not see the problem. Then we were told that what we were giving to our patients is that then American plasma in concentrates. And that made us, and I remember you did that, go back in the history of the patients, that we went back to say whether they got Baxter.
So the two elements that Harry mentioned were first, ignoring the AIDS haemophilia problem. That happened in many places. Second, that not all their patients were getting locally produced concentrates. At this time, blood centers in the Netherlands was making some concentrates, but some were imported. The ratio of local to import varied across regions and also over time. Did you have ideas about changing how you were treating people? Did you have ideas about how to choose products?
There were discussions going on at that time. One of the first considerations was to exclude homosexuals from giving blood.
But I think that decision was indeed taken because the possibility of donating blood was everybody could do it. Yeah, and then I remember the big discussion. Then the blood bank made a decision that they would not accept homosexual donors anymore.
But this was in 1983. There was a meeting with the directors, the medical directors of the blood banks, the homosexual community. It was, I think, together with the Haemophilia Patient Organization, the Dutch Patient Organization.
That meeting, was all stakeholders.
The Ombudsman, who reported on these events, has a different view. His report criticised the government for not including all stakeholders, especially the haemophilia sufferers. There was a large problem with AIDS in the gay community in Amsterdam, so the blood centres of Netherlands had a problem with infected donors, not too different from the situation in USA. One striking thing about Netherlands is the low problem rate with haemophilia and HIV. Some of it seems to be that your government was proactive.
Patients were very proactive.
I think the patients and the blood bank were very proactive, not the government.
No?
No, not the government, the blood bank.
Not the physicians, to be honest.
And not the physicians.
Why do you say that?
Because I think this hope it would not affect us was very prevalent for me.
Okay.
But there was awareness among the blood banks, I remember very well, and there was awareness in the patient community. And the patient organization was very, very active in many different aspects,
Right.
including HIV. And I think they played a role in actually making doctors aware.
There was not much difference in the pattern of use of factor concentrate. Hospitals that used factor concentrate continued to use it. Those using cryoprecipitate historically stuck to that.
I think we had a huge belief in the blood bank. They were very well informed, and they did everything just to reduce the risk of infection. And from the early of 1983, they had a discussion with the homosexual community. So I think I had trust in the Dutch products also.
Yeah, the question is why did we got 17% and some other countries 50 or even higher?
Yeah.
Yeah, like France
80%.
and United States.
Yeah.
I think that was the most important reason is that we had volunteer donors.
No, but that is true for many countries.
Yeah.
But the strange thing, therefore, is, guys, that it tells a story that we were relying on the Dutch system of self-donation, but if that is true in other countries, is that not the reason?
So, what was it that went right? Was it the patient's network, the blood service? It wasn't the government. It wasn't the doctors who, at least some of them, relied on others to take the precautions.
The source is the blood bank.
Yeah.
And I think that at that time, I think the communication with the homosexual community was essential.
Right.
They had a lot of contacts with the homosexual community. Some of the homosexuals just didn't stop with giving a donation, although it was not written down, not clear, but it was just that they just discouraged. Yeah.
So your societal structure allowed it?
I think so. It should be.
That's really crucial because what you're saying is something that has been one of the biggest observations in all of this, that we all depended on voluntary donation as a safety net, but because most countries were afraid to stop donors from donating, voluntary risk donors still continue to donate. But in the Netherlands, because of the community health structures and society's understanding of gays, it was possible to talk to them and persuade them and not put rules. But
it was not against it, but it was just how can we just be next to each other, standing next to each other. And I think it was also at that time the Netherlands was a really free country, free of thinking, free of mindsets. And so we were not opposite the homosexuals. We just wanted to reduce the risk and with discussion together.
Worldwide, there was a distinct identity of the haemophilia community with AIDS compared to the gay community with AIDS. Everything was different between the two groups, including the notion of masculine and the activism with regard to AIDS. We noticed earlier how the stakeholder meetings to discuss blood donation initially excluded the haemophilia community. How did the two groups interact? Would you say that working together philosophy was also true for haemophilia patients group and the gay group?
Yeah.
Okay.
They were very much in contact.
Yeah.
And I think one other aspect...
Although some of the hemophiliacs, they didn't want to go to the AIDS department because that was a stigma, of course, and just...
we avoided that.
We avoided that.
We kept them with us.
Let's now get back to the role of the blood services.
They took responsibility. I know discussions at that time where these directors of the blood bank, they were so concerned. So they were really on top of things when this problem arose to take care of it, which allowed us to keep on ignoring the problem.
Tell me, how does that link?
Now, what I'm trying to say...
Somebody else does the thinking and the acting.
They were so active, they were so concerned, they were open. Yeah? There was no commercial interest in the sense that they had to destroy products. The lack of that aspect made them pretty active and being on top of things. Right. And then, as a consequence, we felt safe.
Right.
So actually it's an ethical question. An ethical that they were just more concerned about the risk of the safety of the products in contrast to the commercial way of thinking.
Yeah.
So the nature of Netherlands' societal relations made it comfortable to discuss the risks of blood donation by the gay community. There was local production of factor concentrate by their blood service. They used small pools of plasma as against the USA factor concentrate, which used large pools. The donors were aware. The patients were aware. Most importantly, they met around a table. So that's the broad brush view of the scene in the Netherlands, one that's less stark than other countries. Let's shift focus to Dr. Madeleine Peters. We've heard her passionately expressing her feelings. What is it like to have been a fellow at that time?
I try to understand my guilty feelings, that to talk with the patients and just to sit next to them and just ask. And they really wanted to talk with me, to all the patients, because they know me from that time. And so for them as well as for me, it is very important just to, even now when I just met them accidentally or with a patient information evening, they really would like to discuss with me that time. And it helps me to balance it more for my feeling.
Who were your supports at that time when you were so upset?
Nobody.
Was there a departmental debrief or?
No, it didn't exist at that time. Now it exists, but not at that time. Home, yeah. Home, direct colleagues, of course, but that no professional help at that time.
Were you married at that time?
No. My husband came in life later, so he actually, I think we never discussed that period with him.
Professionally, do you discuss that period much?
Yeah, with my direct colleagues and also with new fellows with the care of haemophilia. You just have to know the history. And so I tell them the history of the haemophilia treatment or sickle cell treatment or whatever, and also my personal feeling at that time. So I always discuss it with new fellows in pediatric hematology, and that it also can happen then, maybe in the future.
If you had to remember some of the conversations you had in late 80s with patients, what were some of the words you would use to explore the suffering? How would you talk to your patient about the category of the type of problem?
I think, no, not harm, but that it was just that we didn't know, and maybe also the word of guilty, that you feel guilty, although you you can't describe it perfectly, but I just think maybe also sorry. I think that's the most important word. I think. So I'm sorry. We thought that we did the best for you, and
we were wrong.
And we were wrong. So I think that word was we were using the most at that time.
So we've heard 3 doctors from Amsterdam talk about their memories of the early 80s. The forces shaping the epidemic has a distinctive Dutch flavour of active societal participation. A neighbouring hospital used completely different treatment regimens, only cryoprecipitate. So younger patients tended to attend the AMC, and the older patients were happy with their cryoprecipitate treatment. In the event, the AIDS impact on haemophilia was patchy. It was highest in those receiving imported factor concentrates. Netherlands didn't have a judicial inquiry, but they did have an ombudsman reporting. Prof. Harry Buller remembered 2 brothers who complained about Professor Tenkate because that was the only way they could sue the drug company that manufactured their concentrate. They spoke with Harry a few times to convey their regard and apologies to Prof. Tenkate. In the aftermath of medical harm, an apology is required. It's expected. There are many recommendations on how to apologize and what to apologize for. But in long-standing therapeutic relationships, as we've heard from Madeleine Peters, the apology is a constant or recurring theme qualifying the relationship with the patient. Thank you for listening to this podcast.